All right, it is 11:32 Eastern. My name is Nicole Gillen, and we're going to go ahead and get this webinar started. I am the Director of Community Engagement here at Schizophrenia and Psychosis Action Alliance, and my role is to create and drive sessions just like today. So I'm going to get us kicked off, and I'll be handling some of the questions at the end of today's session. But first, a few logistics. This session is being recorded, so if you miss certain parts, you can hear it later online when we compile the recording. You'll notice that the only cameras on are for speakers, and everyone else will be muted during the presentation. However, if you have questions, you can use the chat function, and we will do our best to make sure we address them either in the chat or if it's a question for us about the content during the session. So let's go ahead and get into it. This is a three-part series on innovations in treatment to deal with the main symptoms of schizophrenia and psychosis. So why are we doing this? Well, we want to shed light on the full spectrum of these symptoms. There are exciting new treatments and approaches that our community should know about. And we want to give voice to the people that are in the thick of dealing with these symptoms. Today's session covers what are known as positive symptoms. I think largely we all know about them, but how can we potentially think of them a little bit differently? So in terms of the agenda, we're going to give you some grounding on the symptoms, what we hope to cover in today's session, and a bit of the science before we go into the Q&A with our guest speakers that we'll introduce in a few minutes. So, as I mentioned, today's session is about positive symptoms, as you see here on this chart in green. Our next webinar will delve into the negative symptoms, and then finally in February, we'll wrap up with cognitive. Our goal with each of these is to give strategies, ideas, and practical actions that any of you can take away with. But first, before we get into the heart of the content, let's talk about Schizophrenia and Psychosis Action Alliance. What we do is we shatter the barriers to treatment, survival, and recovery. Founded in 2008, SNPAA, as we're also known, is the only organization focusing solely on schizophrenia and psychosis. We advance systemic change and promote recovery through research, education, and care, in addition to advocacy and public policy, where we are impacting the lives of those with schizophrenia and psychosis spectrum disorders and their loved ones. And we do this in three key ways. First, we have a deep bench of research projects that we both lead and participate in. We have a broad set of services with our resource line and our support groups, and we're building a wide variety of educational opportunities just like today. And it all comes together with the ways we're trying to change public policy through our advocacy work. We have some cornerstone programs where we bring best practice treatment to the forefront. We advocate for equal access and care. We empower the community with knowledge, skills, and support, and we fight discrimination and stigma. So with that as a preamble, I'd like to go ahead and pass it off to our Director of Research and Scientific Affairs. At this point, Arun Nagendra will lead the rest of today's conversation. Arun?
Hi, everyone. Thank you all so much for being here. So I'm going to start by just talking about some of the work SNPAA does. Last year, SNPAA surveyed individuals with schizophrenia spectrum conditions and their caregivers to identify the most common barriers to recovery that they face. These findings form the foundation for our work. So to start with, we know that medications are essential for recovery, but that they often fail to address the full spectrum of schizophrenia's challenges, or they come with significant side effects. This underscores the need for continued innovation to create treatments that target all symptoms while minimizing side effects. Second, our community described how access to treatment remains a significant barrier. only about half of individuals with schizophrenia receive treatment, and fewer than 5% can access comprehensive, scientifically supported care. Most people who have treatment receive only medication, which is a start, but it's often insufficient for recovery. Third, nearly half of individuals with schizophrenia in the community live with caregivers who juggle treatment navigation, daily activities, emotional support for their loved ones on top of all of their other responsibilities. Despite their critical role, caregivers face financial strain, isolation, and even post-traumatic stress symptoms, yet they receive minimal support from the healthcare system. Fourth, we urgently need appropriate housing. Many people with schizophrenia and other psychosis conditions can thrive in supportive housing that promotes stability and builds independent living skills. The lack of these options contributes to why 1/3 of the homeless population in the US is estimated to have schizophrenia or another psychosis condition. Finally, stigma and discrimination are everywhere. Up to 90% of people with schizophrenia and psychosis report discrimination in employment, housing, healthcare, and social interactions. These biases, along with systemic barriers to treatment, further marginalize those with this condition. So SNPA is committed to tackling these roadblocks so that people in our community can recover, thrive, and reach their full potential. You can go to the next slide. I'm delighted now to introduce our three panelists today. First, we have Rob Ramos. Rob lives with his husband, Mikey, and his cat, Opal, in Texas. Oh, somebody's saying it's hard to hear me. Let me see. Is this better? Can folks hear me okay? All right, thanks, Dave. All right, so first we have Rob Ramos. Rob lives with his husband, Mikey, and his cat, Opal, in Texas. Rob also has schizophrenia. He's a freelance artist, and as we'll discuss, his artwork is a critical part of taking care of his mental health. Second, we have Jody Geisel. Jody also lives in Texas with her family. Jody left her job as a teacher to become a full-time stay-at-home mom for her daughter who has schizophrenia. In her words, Jody's goal is to make her daughter's life beautiful. Jody's an active advocate and is particularly passionate about reducing stigma around schizophrenia. And third, we have Dr. David Weiss. David is a clinical psychologist within the EpiNet Early Psychosis Treatment Clinic in Ohio. He's been working with clients who have psychosis for 8 years. And in addition to his passion for therapy, Dave has a particular interest in tobacco and cannabis cessation in people with psychosis conditions. So we're really excited to have them here today. Next slide. All right, so let's start with a little bit of background on schizophrenia. Schizophrenia has 3 types of symptoms. The first are psychosis symptoms, also known as positive symptoms. They're called as such because they are symptoms that are added onto typical experiences that people have. The second are negative symptoms, which are experiences that are kind of missing from a person's usual state, like reduced emotional expression, lack of motivation, and withdrawal from social activities. As you can see here, they're described as symptoms that kind of remove who a person usually was. The third type of symptoms are cognitive. These include difficulties with memory, attention, problem solving, and decision making. Today, we're focusing on positive symptoms. There are 3 different types of them: hallucinations, delusions, and thought disorder. Hallucinations are sensory experiences that occur without sensory input. They are most commonly auditory. About 70% of people with schizophrenia experience these, often hearing voices that comment on, converse with, or discuss a person. Sometimes there are murmurs or whispers, sometimes they're much louder. One particular type is command hallucinations, where voices instruct people to do things, which can influence behavior. You can have hallucinations in any sensory modality, though. Visual hallucinations affect 20 to 40% of those with schizophrenia, causing them to see things like shapes, shadows, or figures. Less common hallucinations involve other senses. So you can have, for example, tactile hallucinations. I once worked with someone who took all of his clothes off in public and ended up getting arrested. And he did that because he felt like his body was covered in snakes. So I would probably do the same thing he did if I felt that. There are also smell and taste hallucinations like smelling burning or tasting rotten flavors, although these are far less common. Delusions are fixed beliefs that persist despite evidence to the contrary. They are a core symptom of schizophrenia, and they often involve paranoia, such as a belief that others are plotting harm. Delusions can also include grandiose beliefs like you have special powers, somatic concerns like your body is infected with insects, or referential ideas like that random events or media are directed at you. Interestingly, delusions tend to emerge before hallucinations and can even shape the themes of hallucinations, such as hearing voices that are kind of aligned with maybe paranoid beliefs. Thought disorder refers to disruptions in organizing and expressing thoughts, leading to disorganized speech or kind of conversations where topics shift illogically. It makes communication confusing and often contributes to social isolation and loneliness among people with schizophrenia and psychosis conditions. Next slide. So positive symptoms can be distressing or even traumatizing to experience. But fortunately, we are in a transformative period for innovations in schizophrenia care. So let's briefly explore advancements in treatments for positive symptoms. Let's start with medication. There we go. Regarding medication, until recently, all antipsychotic medications for schizophrenia targeted primarily a brain chemical called dopamine to reduce positive symptoms, but they often cause side effects like weight gain and metabolic issues. Researchers have since developed medications targeting what's called muscarinic receptors, which affect another brain chemical linked to psychosis called acetylcholine. While the effectiveness of these medications is still being studied, they offer hope for treating symptoms of schizophrenia with fewer side effects. A muscarinic receptor treatment for schizophrenia was approved by the FDA earlier this year, marking the first new class of treatments for schizophrenia in over 50 years, and it became available for prescription in October. So this is a real reason for hope. And also just please note, we don't provide medication advice. Just please note all medication decisions are best made directly between a patient and their doctor. Innovations are also happening in how schizophrenia medication is delivered. While most medications are taken in pill form on a daily basis, new options include long-lasting injectables, which can last for weeks or months, reducing the need for daily pills, which, for example, can be hard to remember to take. Other methods under study include nasal sprays and tiny carriers that deliver medicine directly to the brain, called nanoparticles. Again, these are preliminary right now, but they really may reduce side effects and make treatments easier to take and consequently more effective. You can hit the next button, Nicole. Beyond medical treatments, there are promising developments in psychosocial interventions for schizophrenia, or kind of talk therapy interventions for schizophrenia. The big one here is cognitive behavioral therapy for psychosis. This scientifically supported therapy helps people manage their positive symptoms. It's been around since the 1990s, and it's known to be effective, but here's where the innovation is needed. Right now, only about 2% of people with schizophrenia and psychosis conditions receive this treatment that is known to work well. So the current focus is on ways to expand access by training more clinicians, educating caregivers, and using technology like apps to deliver cognitive behavioral therapy for psychosis. Our speakers will discuss how CBT for psychosis works in more detail. A second type of therapy for positive symptoms, especially hallucinations, involves mindfulness and acceptance-based approaches. These therapies encourage non-judgmental observation of thoughts and experiences, fostering acceptance rather than avoidance or suppression of symptoms. They also emphasize focusing on the present moment rather than distressing thoughts. While the evidence on mindfulness-based interventions for positive symptoms it's mixed and still developing, we're going to discuss how some of our panelists find them quite helpful. You can hit next, Nicole. We're also entering an era of using technology to address positive symptoms. So one approach is brain stimulation techniques called like transcranial magnetic stimulation. This is a non-invasive treatment that uses magnetic pulses to stimulate specific brain areas. And right now we're looking at how they may target like voices in schizophrenia. So during treatment, you sit comfortably while a magnetic coil is placed against your scalp. The procedure is painless. And while research is still developing, TMS, transcranial magnetic stimulation, and other non invasive brain stimulation techniques really do hold promise. We're also looking at virtual reality as another treatment tool. In virtual reality therapy, people put on headsets that immerse them in realistic computer generated scenarios tailored to address their specific symptoms. So, for example, a person with paranoid delusions who fears being followed might practice walking through a virtual grocery store where they're guided to notice that other shoppers, so like virtual characters, are actually not behaving suspiciously and are just shopping. So it's a controlled exposure that can help them reframe their fears in a safe and structured setting. Lastly, there are digital tools like mobile apps and online platforms, and these are also being leveraged. These tools often include features like daily symptom tracking, guided exercises, and coping strategies tailored to the user's needs. For example, people may log experiences with auditory hallucinations, so they may say, I'm experiencing this right now, and receive real time guidance like, here's a relaxation technique, or let's see if you're taking your medication, or here are strategies to challenge unhelpful thoughts. So these kinds of digital tools are exciting because they're accessible and they have the potential to like reach more people on an exponential basis. So we are truly in a hopeful time for schizophrenia and other psychosis conditions. So with that, let's move on to hearing what our panelists have to say about positive symptoms and their experiences with treatment. I also just want to note, I'm noticing a few people are sending me direct messages with questions. Just because I'm moderating this, it's hard for me to look at them. If you can, please direct them to Nicole or Davey. Thank you. And they'll handle them, and we'll try to loop back around to them. All right, but we can go ahead to the discussion now. All right. So we're going to start by talking about the experience of positive symptoms, what it's like to have them. So I'd love to start with you, Rob. Rob, could you tell us a little bit about what it's like to have positive symptoms?
Sure. My positive symptoms are pretty much auditory.
Mhm.
I do have hallucinations as well. Um, my hallucinate or my yeah, the voices that I hear tend to be pretty intense. Sometimes they're very commanding in nature, and sometimes they're just saying things to me to scare me. My therapist tells me they're a lot like a bully. Whatever I value and love, they will come in and twist it and turn it and make it something that is unbearable for me to deal with. And then sometimes my voices can be nice, where it's not telling me to do something bad, but it's telling me to do something that's not logical. I was at a church one time and I heard this guy talking about how he didn't have a car, so immediately I heard a voice say, "Give him your car." And because a lot of my voices are religious in nature, like I think God's talking to me, or the devil, or angels, or demons, I thought that was God talking to me. So I just gave him my car, and which made no logical sense. Luckily, my dad got my car back for me, but I would have to say that positive symptoms, voices, hallucinations, it's hard to deal with. It's a daily battle. So
Thank you, Rob. And, I've heard that voices can be influenced by important themes and emotions in your life. Has that been your experience?
absolutely. My faith, number one, is very important to me, and that's been twisted and just people normally get, there's various faiths, but a lot of people that have faith get comfort in their faith. Well, for me, it's the exact opposite. It's torment for me. Um, it also affects like my art. I'm an artist, and I will be feeling really good about my artwork, and then all of a sudden a voice will say, "You're no good. You're not an artist," and it puts me down and makes me feel bad, and my confidence is very low anyway. So I'll stop painting because this voice told me that I'm no good at it. So it's the voices can be different. It's not a male or female voice. It's more just a neutral voice that I hear. And sometimes it can sound like me too. So,
Thank you, Rob. And Jody, what, from your perspective as a mom of someone with schizophrenia, what do you feel like is important for people to know about the experience of positive symptoms?
Well, my daughter, especially early on, she was diagnosed in 2019. She's 23 now. She was experiencing hearing voices. She was seeing things that weren't there. Um, and she still does some. Uh, she will, for example, she will. I have trouble with delusions because I don't know how big a delusion has to be considered a delusion. But her brain will get stuck on something such as, I feel sick every time I eat chicken. She'll stay up all night worrying about chicken and researching about chicken and the health benefits, or it might have poison in it or bad things for us. And it's like she can't get her brain unstuck from that topic, and it'll last for a while and then it'll just go away. And when this all first started happening, she was hearing voices, and the voices were telling her she was ugly, she walked funny, she held her neck funny. And we were on our way to the mall when this started happening one of the times, and it really upset her. And, to this day, in 2023, she's probably been to a mall once. And she thinks anywhere she goes, a restaurant or a mall, anywhere where there's a lot of people, that they're all going to be telling her that she's ugly. And so I think in some ways the positive symptoms have kind of taken who she was meant to be.
Thank you, Jody. And Dave, as a clinician, can you comment on what Jody said earlier about how sometimes it's hard to know how to define a delusion? Why might that be hard to do sometimes, and how do you think about it?
So if we're talking about delusions, we're talking about a belief that in some way departs from reality, or from the truth of a reality-based experience. So just going off what Jody was describing with her daughter, what can make that blurry is people in fact can get sick from chicken if it's undercooked or not prepared properly. So sometimes these ideas, these delusions can be based off of a kernel of truth. I like to think about, there's a psychiatrist, he's written a couple textbooks about psychosis named Michael Garrett. He will describe positive symptoms as representing literal falsity, but figurative truth. So, the fact is the chicken, Jody, I'm going to trust that you're preparing the chicken safely. But there's nothing wrong with the chicken, but it evokes fear, in Jody's daughter, and that fear is real to her. But it's in fact based off something that isn't so tied to reality. Yeah. I think the other thing I'd like to add just about positive symptoms is, I could give you a basic description of what positive symptoms are, but everyone's experience is different. Rob was kind of alluding to this before, but if someone is kind of preoccupied with religious ideas, let's say, for some people that could be a very positive thing, can be impairing, but maybe not distressing. Whereas, Rob's experience, it seemed to be way more distressing and overwhelming for him. So I guess I would just say, I think it's important to listen to people's experiences in an effort to understand, what their positive symptom experiences are like.
Thank you, Dave. And now we're going to move into talking about your experiences with treatment. But before we do that, I want to highlight a theme that came up in all of my early discussions with you, which is about the value and importance of trust in therapeutic relationships and in relationships between caregivers and the person with psychosis. So, Rob, can you talk briefly about why trust is important to you and how your treatment providers built that with you?
I'm not a very trusting person by nature. I tend to be a little bit paranoid about people and trusting people. Um, I have been through, since I've been in the psych realm since like age 15, a young boy. And I've seen a lot of therapists and I've seen a lot of doctors. And it's just now at age 40, why I acquired my therapist and my doctor by age 46. Um, and I trust them both completely. And it's because they proved to me, like my doctor, he put me on a new medicine and he called me every week to check on me. And that's unheard of for a doctor to do. I also have a therapist who it took me a little bit to trust her, but after I saw the benefit of what she was helping me accomplish to get over some of the symptoms, my trust level just went way up. So it took me a while to warm up to them, but now I love talking to them. I feel I can tell them anything I want to. So yeah, it's good.
Thank you, Robin. Why is that important for like your treatment and, for example, taking medications or sticking to the treatments you're prescribed?
It's important, like taking your medicine. For me, therapy is just like taking my medicine. It's just as important. Um, because I early on I thought I had the point of view where I'll just take a pill and it'll all go away. And that's not the truth. There's a lot of hard work that goes into taking your medicine, which does help to a degree, and having your therapy, so you can work through some of these hallucinations and delusional thinking and stuff. So it's for me, it's vital.
And
Yeah.
I imagine that the trust is something that really leads to you maybe like wanting to take your medication more or
Yeah.
sticking more and engaging in these treatments,
And
right?
I guess it's been a little bit of the more I trusted them and did what they told me, the more I built my trust. So
Thank you, Rob. All right. And Dave, can you talk about trust in your kind of work and how you build that with clients? Why it's important?
I think the theme I'll hit on again is listening is key. So I think early on when you're working with someone, it's important to listen and from what they're telling you to try to build a common language based on what they're willing to share. To give you an example, early on in my career, I worked with a young college student who would tell me about becoming quote unquote stressed in the middle of class, and they would run to the bathroom and scream into balled up paper towels. Now, in my mind, when I think of being stressed, I think of anxiety or being overwhelmed by overstimulation of some kind. But over time, I came to understand that when they were using the word stress, they were referring to instances where they were being yelled at or are bothered by auditory hallucinations. So, from there, I felt like I better understood her experiences and we could try to figure out ways to better address being stressed that didn't necessarily have them run to the bathroom and scream. I think the other thing I'd say too is I think as clinicians, we can sometimes overemphasize the symptom experiences that we become so focused on reducing or changing positive symptom experiences, and that may not always be possible. I think, we also want to make sure that we're focusing on what someone's goals are. What are they trying to achieve, in their life, in the short term and in the long term? And part of the work, I think, is figuring out how to achieve those goals in spite of positive symptom experiences that people may have that may not be changeable.
Thank you. And Dave, I want you to speak just to one more part of this because I've seen we're getting a few questions on kind of insight into illness and this idea of anosognosia. And often I think as a therapist, people probably come in and they may not be on the same page as you as like what's going on. So can you just briefly kind of explain how you think about that and what kind of suggestions you might have for folks on how to work with that problem? Because it's a very common one in schizophrenia.
It is a very common problem. And it can be really challenging, I think, for everybody. And it can be really frustrating for everybody, including the person. So I think in those situations, what tends to be emphasized is the point of disagreement. So, it's a kind of tug of war, I'm not sick, yes, you are, I'm mentally well, you're not, you kind of get bogged down in that argument. So what I was kind of alluding to earlier is maybe if you can try to pivot your focus to what goals are, right? So we can agree that, everyone wants to support goal achievement or goal attainment. And maybe the point of or maybe the point of agreement can be you're having a problem achieving or getting to the goals that you have for yourself. We may disagree about what's causing that or what's preventing you from achieving your goals, but we can agree that you're having difficulty achieving those goals. Can we try to agree or figure out what would be helpful in helping you achieve that goal?
Thank you, Dave. All right. And Jody, I know that you said your daughter is currently not in therapy, although she's seeing a psychiatrist, and you kind of explained that's a little bit because she feels anxious or self-conscious. So rather than talking about her relationship with her therapist, I'd love to hear from you about the importance of trust in your relationship with her, how you built that, and why it's important.
Well, trust is key to everything from medication compliance to just her living her best life. I think when trust is established, it just makes everything easier. And when she started with positive symptoms, it was so important to me that she was able to tell us that, hey, this is what happened to me. I can't imagine going through this by yourself. And I knew then too that my reactions to her positive symptoms needed to be calm. She needed to be validated, so that she wouldn't be made to feel weird or strange or the sky is falling. Oh my gosh, what are we going to do? And I think that she trusts us and trust me that I'm going to keep her safe. And I'm going to encourage her to do the things that she needs to do to live her best life every day, taking care of her needs, personal needs, and taking her medication.
Thank you so much, Jody. Now let's move on to some of these treatments that we described earlier. So Rob, have you tried any of the treatments that we described earlier?
I would say CBT, definitely.
Yeah.
My therapist, that's kind of her major treatment plan for me is to learn cognitive behavioral therapy. And I found that it actually works. And I guess you could also use a little, she teaches me mindfulness too, to be mindful and to stay in the present and not get caught in my thoughts or my hallucinations.
And Rob, let's start with CBT for psychosis.
Okay, CBT.
Go ahead.
Oh, I'm sorry. A basic one example of CBT is okay, she says if you're having your mind starts spinning, you're having voices, you're having hallucinations, you go do something tangible. And my favorite thing to do is paint. So I will go get on my canvas and paint my emotions out. And for a few hours, it's like my symptoms just leave. I mean, I know they don't, but I have a break and I'm able to think and focus. So she's always teaching me whatever negative thoughts come to your brain, counteract it with the positive, or do something opposite of what your mind is telling you to do.
Thank you, Robin. When we were talking earlier, you gave this example of reality testing, which is a key component of CBT. In about a minute or so, can you just describe what that, like an example of that and what that looks like for you?
For me, whatever I can see, touch, taste, feel, things that are real, not what my head is telling me. Reality testing, one of the things that I have is a fear of dying in my sleep. Well, I did some reality testing on that, and I would say, okay, I'm going to die in my sleep. And I'd go to bed, and I would always wake up the next morning. So it's kind of taught me that delusional thought, that inaccurate thought could be defeated by just facing it head on. And I can do that with a lot of things. I used to, obsess about checking clocks or the oven is on and stuff like that. And now I don't do that. I use my CBT to do something more constructive. So,
Thank you, Rob. And Dave, how about you? What are your thoughts on CBT for psychosis, and do you use it with your clients?
I would say, cognitive behavioral therapy for psychosis is the predominant mode of treatment that I use. I'm a psychologist, so I feel well versed in the psychosocial treatments that you mentioned earlier. Um, I think it's a great treatment because I think ultimately it helps people understand their symptom experiences, and then if I can understand symptom experiences, I can collaborate with them to see what kinds of skills or strategies or techniques that may be helpful in helping them influence, their symptom experiences or help them achieve goals. Um, I'd say it's a principle-based treatment, so a good clinician should be able to tailor the information to the individual. Just if you think about it on a kind of basic level, cognitive behavioral therapy. So you're trying to understand cognitive factors like thoughts and then behavioral factors. So there are some people, thoughts are really tricky to understand. I mean, they're intangible, they can be abstract. So if someone is having difficulty, I may not focus so much on cognitive techniques. We may, veer more toward behavioral techniques, and that's okay. Anything that may put someone on a better footing to help them exert control or agency over their life, that's what the treatment I think is ultimately about.
Thank you. And one thing that we talked about, Dave, while talking about therapy is how you as a clinician can work with caregivers and how you do work with caregivers. I know this can be kind of tense, especially given like the issues of like insight and anosognosia. And so how do you work with caregivers?
Well, first, I want to just acknowledge and state that I'm really fortunate in that I work with a team here at Ohio State. So, I work with psychiatrists, case managers, people who are all about family and community outreach. So, um, that is important for me because we're able to offer services just for caregivers, just for the client or the individual. I would say, in general, I encourage communication between myself, the client and the caregiver. But if I'm, the client's individual therapist, ultimately the decision is up to the client. I think we've mentioned this throughout the panel. Trust is really important. And, as a psychologist, confidentiality is a really important principle. So, I do my best to try to clarify this with the caregiver. I'd offer them to join our family group as a way to address their needs. But so while I prefer the lines of communication to be open, I really do allow the client to guide that. Over time, that may change. Time helps build trust, but that can be really frustrating for a caregiver who wants to be really involved in treatment.
Yeah, thank you so much, Dave. And I know that that is a challenge that so many caregivers who come to us experience. Like they feel kind of like a little bit shut out from their loved one's treatment, or very shut out from their loved one's treatment. Um, Now let's talk about some of the treatments that we have not yet discussed, such as medications that target muscarinic receptors, transcranial magnetic stimulation, and use of apps. Rob, when we spoke before, you said that you'd be open to using any of these novel treatments. And specifically, you mentioned that your medication does not entirely treat your positive symptoms. So you've been taking medications for a decade, and yet you still hear voices.
Yes.
How would you make the decision about whether or not to change medications? And how do you feel about kind of this new medication on the horizon?
That's a good question. I feel great about new innovations as far as medicines go. If they have a medicine that's better or more attacks more of the positive symptoms and the negative symptoms that I have, I would totally be open to doing it. I would probably talk to my doctor first and say, hey, this is what my thoughts are. What do you think? And then I'd probably talk to Mikey, my husband, and see what his thoughts on it were. But I am open. I'm very open. I'm an open-minded person to trying new things that might help.
Great. Thank you so much.
You're
And
welcome.
Jody, how about you? How would you think about trying any of these innovative treatments, and especially for now, medication?
Well, for sure, if her medication stopped working, which she's only 23, is it still going to be working when she's 43? We would be open to any new medication or any other of these innovative treatments. We would do research, talk to her psychiatrist, make sure there's no long-term side effects. But it is always in the back of our minds what else is out there, because we don't know. We don't know if her medication will continue to work 10 years from now, or what if our insurance changes? What if we can't afford her medication anymore? What happens when my husband retires? I mean, and she's not on his insurance anymore. It is, and we would be open to anything that would just let her have a better quality of life.
Thank you. And how about you, Dave? What do you think of some of these innovative treatments? And as a clinician in kind of this big treatment center, do you have access to a lot of these innovative treatments yet?
I'd say some. I think one benefit of working in a large university is that we do become aware of newer treatments. And like Cobenfy, I think is a really good example. We're talking about that. We're talking about, the psychiatry team is talking about how they may incorporate that as a second line treatment per se. I think, as I was saying before about everyone has a kind of unique symptom experience. I think the same is true when we're talking about response to medications or treatments. Now, science will give you a kind of general or average response for a group of people, but you could have someone that responds better than average, and you could have someone that it has a response that's worse than the average. So, understanding that everyone's response to treatment is different. I think treatment and medications can be helpful in reducing or lessening positive symptoms. But especially if we're talking about medications or biological treatments, they can result in side effects that are just as impactful as, as positive symptoms themselves. So I find that, I think my work is trying to help people manage their symptom experiences. It is about trying to achieve personal goals, but it may also be about trying to navigate side effects or trying to figure out, whether this is ultimately helpful in terms of trying to achieve goals I may have for myself.
Thank you, Dave. And I know we're getting a lot of questions, so I'm going to ask one more question to each of you, and then we'll move into the Q&A. So let's just wrap this up. I'd love to hear from each of you. What else do you think is important for people to know about schizophrenia? Just in a minute or so. Rob, what do you think?
The most important thing, if someone's been newly diagnosed or they have friends or family that are helping them, is to realize it's a journey. It's a lifelong journey. It's not like you're going to take a pill and you're going to be better. Every day I deal with it. What I would encourage is that you can have a good life and have a hopeful life and still have schizophrenia. So I would just encourage people that are diagnosed to just hang in there and your life can be just as normal and just as good as everybody else's.
Beautiful. Thank you, Rob. What about you, Dave?
I love what Rob said. So I'll kind of echo that. And I would say, I think an important take home message is people with schizophrenia or with psychosis concerns are capable. Um, Certainly a diagnosis can be an adjustment. Certainly life changes, but people are capable of achieving things for themselves. I think we've had a lot of good examples. I'd stress that point.
Thank you. And lastly, Jody, what is the takeaway you'd like people to have about schizophrenia?
I echo everything that has been said so far. Absolutely. My daughter is just an example of a beautiful, creative, kind human being who happens to have schizophrenia. They are not monsters. It affects everyone differently. It's sad the way it's portrayed on TV and in the movies. I think that's very destructive. But it's different for everybody, but absolutely you can still have a quality of life. It takes some work and it's not easy every day. Absolutely, it's not easy. Sometimes every day is different, but it is a journey. But these are very wonderful human beings that deserve, any kind of advance in treatment, support, um, anything that they can get, they deserve.
Thank you, Jody. I am so grateful for all of you for your time today. Thank you so much for sharing your thoughts and your stories. We're going to move into the audience Q&A now. So I'm going to hand over back to Nicole for that. I think it would be great if you could all stay on camera to answer these too.
Awesome. Thanks, Arun. And you guys, this has been a fantastic discussion. And for everyone who's on the call, who's been throwing questions at me, I've been typing furiously trying to keep up with everyone because there's so many really interesting and just painful questions, to be honest. But one question that has come up repeatedly is around anosognosia. And I think I have at least 5 or 6 different questions around anosognosia. So let me try to distill it down. It's a huge problem. How do we overcome it? I mean, at the end of the day, if somebody doesn't understand they're sick, how do you give them treatment? How do you get them to take meds? David, do you want to try and take a whack at that?
Sure. So what I was trying to get across earlier is that I think sometimes we overemphasize the problem, the symptoms, and it detracts from, I think, shared goals that the family and the individual has. Um, I mean, and of course, easier said than done, but I think when a family member or a caregiver just sees, schizophrenia or psychosis as the barrier to the problem, it's tough to focus on anything but that. In terms of resources, I just kind of discovered this not that long ago, but I really like Dr. Amador's work. Um, so he has something called LEAP. It's an acronym. LEAP stands for listening, empathizing, agreeing, and partnering. And there's videos I think you can view on like demonstrations of how conversations may work with someone struggling with insight. So that would kind of be a recommendation for the audience who's encountering that themselves.
Wonderful. Thank you, David. And Rob, have you ever had a moment in your life where you didn't really understand that you were sick? Did that ever happen to you?
Oh my gosh, yes. In my 20s and my 30s, that was a battle. And I think part of it was denial. I didn't want to have a mental illness. So it was more of self-denial. Um, but the more I denied it, the more symptoms would come up and the more obvious it became to me. So I finally had to go, I'm going to embrace this diagnosis and I'm going to make my life the best that it can be, even though I have schizophrenia. But I went through, people would tell me, Rob, you're mentally ill. No, I'm not. No, I'm not. And you need to take these medicines. No, I'm not going to take medicine. I'm not ill. But it was me. So it was just denying the truth that was right in front of my face. And I didn't know. I think you and I talked one time about, how do you say it?
Anosognosia. Yeah.
Anosognosia. Yeah, that's right. And it's a real thing. It is a real thing. I'm a believer now. So
Well, and the funny thing is I personally, I think you're too hard on yourself. I think when you have anosognosia and you don't know you're sick, like I don't think you were denying it because of the stigma. I think it was just part of the symptomology.
yeah, you're right.
And, I mean, I want to give you the right to give yourself grace, baby, because, it's a thing.
Yeah.
Jody, from your perspective, with your daughter, did she struggle with anosognosia? And if so, what'd you do?
Thank goodness we have not had to struggle with that.
Okay.
We have not. I mean, at the beginning, of course, she was having to process all of this information coming at her with her diagnoses and didn't really want to deal with it. But I don't think it was that. I'm very thankful. I'm very thankful we have not had that roadblock yet.
That's a beautiful thing in some weird way, right?
Yeah.
And Arun, let me ask you from a research perspective. I know that you're sort of thinking about anosognosia and how we want to look at it. What are your thoughts?
So we have started a research program on anosognosia, and a starting point for it is actually really trying to understand what different stakeholders think about this, because it is a pretty contentious issue. I will say, it's something that language is something that's frequently used in the caregiver community, but less so in the research and clinician community. And I think that's that's obviously a pretty big point of contention. The way I'm kind of currently understanding this based on some of the work we've done so far, is that there's this kind of condition, right? Like everybody agrees there's this condition where people with schizophrenia or psychosocial will often say, I am not sick, I don't need treatment, etc. And there are our understanding right now is there are multiple causes of that. Rob alluded to how, maybe sometimes people won't say they have schizophrenia because of stigma. Anosognosia is considered a neurological symptom, right? Where people, like Nicole said, people are unaware that they have schizophrenia or an illness. But, when somebody comes into the room and they say that to you, we don't know if it, what the underlying reason is. We don't know if it's because of a brain condition. We don't know if it's because of stigma. We haven't fully figured out how to assess that. That said, we do know there are brain differences in people who have high insight into their illness and low insight into their illness. So I would echo really for now that we really do need more research on how to address this. It's so important because it's such a pervasive issue. And also, the best thing I think we have right now beyond medication and some options like AOT when it might be appropriate is stuff like what Dave said. I think rather than as a clinician, you always start by saying, what are your goals? What matters to you in your life? Where do you want to go? What do you want to be doing? And use that as a common ground and a starting point so that you're not kind of directly tackling or arguing with this thing that really might be potentially so neurological. And so that's how I would think about it.
Excellent. All right. So we only
Nicole,
have.
can I add something?
Yeah,
Can I
go
add
for it.
something?
Yeah.
I mean, just imagine if someone told you, I know your mind better than you know your mind, or you know yourself. I mean, I would be incredibly troubled by that. So, I mean, try to put yourself in that person's shoes and how it would feel if someone was telling you something that you did not recognize or did not see in yourself. It would be quite disturbing, quite distressing.
Yeah, I mean, absolutely. And they're already struggling with all these other things going on. And then to have someone say that, very difficult. So David, there's a lot of questions for you, but I'm gonna pull this one out as a starter, and then I'm gonna flip it to maybe Rob and Jody. So the question is, what is the best way to get your psychiatrist, and I know you're a psychologist, but try to sort of envision you're a prescriber as well, to agree to trying these new medications? And look, I am a caregiver, and I know I've had difficulties in trying to get my kiddo's psychiatrist to consider something new. What is the best way to have that dialogue?
Take it first.
Yeah, Dave, why don't you go first? Yeah.
Sure. You're right. I am a psychologist, and there are things about medications that I myself don't understand. So, often I find I have conversations with clients about how to approach these conversations with the psychiatrist, the kind of questions to ask, write them down so you don't forget when you have that kind of appointment. Um, what are the potential side effects? What are the potential dosing considerations? How much time may this take to start exerting effects? I think the other difficulty with this is I think too often we view medication as a panacea or cure-all. And I mean, it makes sense. We're kind of socialized to believe that, right? If I have some kind of infection, I'll take an antibiotic and it goes away completely. You have a viral infection, you take something and it goes away. That may not be the case with some of these symptoms in schizophrenia. You may only get partial relief. I mean, there's just so much involved, so many considerations. So just trying to formulate important questions so that a psychiatrist can guide you and give you important information for you to make a decision.
Yeah, so a lot of it really boils down to the gathering the information, talking about the strategy, talking about the possibility to try and get everybody aligned. Jody, have you ever had to try to introduce your daughter's psychiatrist to new medications and have that conversation?
We have not really at this point, but I do want to add, that knowledge is power. And I think as a caregiver, you it's good to stay educated on top of things the best you can as far as what's out there. I also think it goes back to that trust thing.
Yeah.
Even with the psychiatrist, you've got to have that open and honest relationship where you have a trust for each other. So when something does come up, you feel like that trust is already there as a foundation.
That is an excellent point. And Rob, give us one more final point and then I'll close this out. Anything you want to add to that question?
Not really. I know that my doctor is open to suggestions, but I trust him explicitly, so I'm kind of just taking his lead.
Yeah.
Mm.
Yeah.
So,
I would say you are lucky, my friend, because unfortunately not everybody has that. But I think Jody, I think your point about knowledge is power and trying to, understand your strategy for the change you might want either for yourself or for your loved one. So we are at the bottom of the hour exactly. And I have probably another 30 questions that have come in that I have not had an opportunity to get to. But you guys, we're going to go ahead and compile all those questions and figure out a way to get back to people later with responses. And so I want to thank, Dr. David Weiss, Jody Geisel, and Rob Ramos for being just amazing guests on today's webinar. Arun, thank you for your leadership in driving today's conversation. As I mentioned at the beginning of the call, this is going to be recorded. We are hoping that in terms of maybe some takeaways from today, that, we all understand that positive symptoms are incredibly emotional for everyone. They reflect someone's emotional state, what's important to them, their relationships, their faith, their goals. But that trust is so important for everyone in this process, and it is foundational to addressing these symptoms. Obviously, medication is critical, and it is that first line. And then there are a number of therapeutic approaches, whether it's DBT or CBT, that trying to ground yourself in reality testing and mindfulness are also fantastic strategies on how to get yourself to a comfortable place despite psychosis. That creating a common language from both the diagnosed person to the caregiver to the clinician can improve outcomes in positive symptoms. And that considering these newer treatments in the ecosystem from which you live, your doctor, your loved one's doctor, your care system, your friends, and trying to figure out what your individual pros and cons might be, and looping in just the importance of your entire environment and the structure around it. There's a lot here. So hopefully today's webinar has been informative. As everyone knows who first logged on when I gave the introduction, we're going to have 2 more webinars after this. And our next one is going to address negative symptoms, and our final one will address cognitive symptoms. So if you're not registered for those, you can go back onto our website where you can register for the second and the third webinar. And then we will post today's webinar in hopefully about a week or so online. We'll send everyone a link so you can listen to it in its entirety. So with that, I thank all of our guests. I thank everyone who attended, and more to come. So thank you, everyone. Have a great day.